Good morning, everyone. So today, what we are going to start is pancreas. We have done liver, we have done gallbladder. So pancreas is also one of our important structure in the abdomen. So now, the conditions which we are going to talk about in pancreas will be mainly surgical. In internal medicine, you have covered already pancreatitis. So that's being the a very important topic which you have to cover, but of course, like that's covered already in internal medicine. One of the thing which we will discuss is like the complications of pancreatitis in this lecture, and of course, like we are going to talk about the introduction, some basic anatomy, some basic physiology, and then we are going to discuss the surgical causes, problems like especially pancreatic carcinoma. Uh, we will be covering in this lecture. So regarding pancreas, I think like all of you and all of us, we know like the pancreas is a retroperitoneal structure, and uh, it is located. Uh, you can say duodenum is surrounding the pancreas from three sides, and like as you have already covered pancreatitis, so you are like well familiar with the functionality. So now regarding anatomy. Uh, you can see over here like the gland can be divided into four portions, which is head, neck, body, and tail. And there is a pancreatic duct, which is running all over like through the gland. And this is the duct, by the way, which uh, either entered into the duodenum alone, or most of the time it is attached with what you can say uh, the other duct from the liver, pancreas, gallbladder, and it is entering into the second part of the duodenum. So uh, now the important point here is, like you can see over here, this is the duodenum, ample of water, sphincter of Oddi, and this is pancreas, and the duct is running all around in the pancreas, right? So basically, there is a lot of variations, in the pancreatic duct, and to understand that, of course, we have to see the embryology of that. So because the pancreas is formed by the fusion of the anterior and the posterior buds, and that's the reason that there is one duct from the from the anterior side, which is a small one, and which connect directly to the common bile duct, and there is a larger duct from the posterior side, from which arises from the duodenum, and it drains directly into the duodenum. So and the one which is basically from the anterior side is also called as the duct of Versunk. This one, the duct of Versunk, right? Okay. So anyhow, there is a lot of variations, in the anatomy of this thing. Okay. So the variations, of course, like if you will start discussing variation, it will take a lot of time. But if you will go and read a little about embryology of like how the pancreas is developed or formed, you would have a very nice concept about, because there is a dorsal and ventral bud, and then they rotate together, and because of that these ducts are formed and they are rotated. So uh, just to just like to tell you, like there is duct of Wirsag, and this is also one of the ducts. So one of the duct combines with the bile duct and enter into the duodenum, whereas the other duct, it opens directly into the duodenum here. So you can see over here the main pancreatic duct is around 2 to 3 millimeter in diameter, okay, and runs midway between the superior and the inferior border, okay, of the pancreas. So there is more pressure inside the pancreatic duct than the common bile duct. So that's one of the reason, that there is, like, of course, that's one of the reason, like, the bile never flow in the pancreas. Of course, if the pressure in the pancreatic duct is less than the bile duct, so what will happen? Of course, the bile can enter over here. So the pressure in this duct is more than the bile duct, so that's why the pancreatic juices, they flow in this direction, not like the bile never enter the pancreas. So a very, very important thing to know, because there is no walls, by the way, in this one, right? So the blood supply of the pancreas come from the multiple branches from the celiac and superior mesenteric artery, okay, from the celiac and superior mesenteric arteries. So the common hepatic artery basically give rise to gastroduodenal artery, okay, and the gastroduodenal artery then becomes this one, superior pancreaticoduodenal artery. So this one is coming from what? This one is coming from gastroduodenal artery. And see, then this one, it passes from the first portion of the duodenum. This is the first portion, okay, and then branches into the anterior and posterior superior pancreaticoduodenal arteries, okay. So and the superior mesenteric artery, like you can see over here, it passes behind the neck of the pancreas, behind, okay. So this is the neck of the pancreas. It passes behind the neck of the pancreas. It gives off the inferior pancreaticoduodenal artery, okay, here, and and then later on it gives like the other branches, okay. So like this is like the main blood supply, so coming from the up, coming from the down, okay. So what you can see over here, that the arteries, this is the splenic artery. So see, there is a lot of anastomosis, if you can see, like many arteries, they are communicating with each other over here, right? So so one of the good thing of this layout of blood supply is what, in, for example, carcinomas, when they have to, for example, resect the head of the pancreas, okay, so they can resect one part and the blood supply to the other parts are still there, okay. So this is one of the point, like I am discussing over here, like this one have surgical implication, like when we divide or when they resect the pancreas, so the blood supply to the other areas can be maintained. And now again, like there is a lot of variations, uh, in pancreatic blood supply. There is a lot of variations, but of course, like we are not going to discuss variations over here. So simply, this is hepatic artery proper coming, okay, and this one is going towards the liver, right? So this one is abdominal aorta, you can see over here. This is the big one, is abdominal aorta. Abdominal aorta is the one which gives the celiac trunk. So this celiac trunk gives the common hepatic artery, which gives hepatic artery proper, and then it comes down. and it gives branches to the duodenum, as well as it can give branches to the pancreas. And this one, the one which you can see in the dotted line, is basically behind. This one is passing in front, and this one is going behind. Okay, so both of them, they are giving branches. And you can see, like the other one, the splenic artery gives a lot of branches behind, right? So this is how the blood supply to the pancreas is done. So of course, like this one is superior mesenteric artery, as you can see, like of course it is also arising from the aorta, and see, they both are communicating with each other. So see, so this is one of the thing that the blood supply is extensive. Again, one more blood supply diagram: aorta, inferior vein, inferior vena cava, pancreas, and like see how is the relation of pancreas with the spleen, with the left kidney, with the right kidney. So the venous drainage of the pancreas, they follow the arteries, and what happens that it forms the anterior venous arcade and the posterior venous arcade, and the superior veins drain directly into the portal vein. Okay, portal vein, they go into the portal vein. Of course, like that takes the blood to the liver, and the anterior veins, they join, and they join with the right gastroepiploic vein, and they what you can say, they enter into the superior mesenteric vein, which ultimately drains into the portal vein. So this is how the vein supplies. And the lymphatic drainage from the pancreas is widespread, because there is a lot of network of lymphatic vessels and lymph nodes which basically drain the pancreas. And what you can say, that's one of the thing, like the importance of this thing. What I'm telling you is, like, there is extensive lymphatic drainage, and which basically drain into the lot of lymph nodes. So that is one of the reason that whenever someone have pancreatic carcinoma, so there is a lot of lymph nodes. They take biopsies from those lymph nodes, and positive lymph nodes when it comes, so it means like the cancer is spread it already to the lymph nodes. Okay, and that's the reason, like when they take out pancreas, they also take out the lymph nodes around that. So this is the main thing. Okay, so physiology of pancreas, like we know that pancreas have two type of functions. uh, One is the exocrine function, and one is the endocrine function. And we know that, like pancreas is made up of uh, acinar cells, and also there is what you can say, islet cells. Okay, and we know, like the pancreas is the one which basically form insulin. Okay, so like and how insulin function, of course, that is what you can say, the important function of pancreas. So so endocrine function, sorry, of the pancreas, right? So now, if we will talk about the exocrine function of the pancreas, so basically the main function, or the main thing which pancreas produces, called as pancreatic juice. Okay, and what pancreatic juice have? It have enzymes. And what kind of enzymes? Like, these are the enzymes which basically help in digestion. Okay, so normally you can say pancreas, it releases around 750 to 1000 milliliter in 24 hours of digestive juices, which is clear, which is alkaline, right? So now, uh, what this digestive juice is having is basically amylase, proteases, and lipases. And basically, if you know that what is the function of proteases? Proteases are those, which digest proteins, and amylases are those which digest carbohydrates, and lipases are those which, of course, break down fats. So simply, pancreas is the one which is giving the secretions or digestive juices, and that's why we call it as digestive juices, because, or digestive enzymes, you can say, because this is the one which basically help in breakdown of proteins, help in breakdown of carbohydrates, and help in breakdown of fats. Okay, so uh, this is one of the thing. So we all know, if, for example, there is blockage in the pancreatic duct, for example, what will happen, that these digestive juices, they cannot be released into the GIT or duodenum. And what will happen, of course, when they started accumulating inside the pancreas, so they basically uh, started digesting or started damaging the pancreatic structures. And we know, like, all the structures are made up of what? All the structures are made up of proteins and carbohydrates, okay, and fats, okay, peptidoglycans and all these things. Of course, in biochemistry, like, these are the building blocks. So this like, the you can see over here, the secretion is stimulated by the hormone secretin and cholecystokinin, and also by parasympathetic vagal discharge. We know, like, parasympathetic, uh, what you can say, discharge, or parasympathetic system promotes rest and digestion simply. So you can see over here, like, rest is what is like, how secreted in CCK or cholecystokinin, what is how did they are released, what are the stimuli they get. Simply, uh, pancreatic amylase, by the way, they are basically in inactive form when they are, uh, what you can say, uh, once they are, what you can say, they are excreted. Okay, so, like, what happens is that they hydrolyze, or they start breaking down bigger glucose molecules, or like bigger carbohydrates, like the glycogen to glucose and maltose and all these things. So simply, and same thing with, what you can say, the other enzymes which uh, pancreas give. Sorry, one thing, I said, I think I said inactive form. I said, like, pancreatic amylase is released in active form, whereas the proteolytic, or the protein digesting or breaking down enzymes, they requires activation. Okay, so for example, trypsinogen is converted into its active form called as trypsin. Okay, and then there's an enzyme. There is an enzyme, by the way, which do this thing, and that name of that enzyme is enterokinase. So so, like, this way. So uh, see, enzyme synthesized, stored as zymogen granules, and released by the SNR cells of the gland. 85% of the cells in pancreas are SNR cells, right? And pancreatic enzymes are proteolytic, lipolytic, and amylolytic. Lipase and amylase are stored and secreted in active forms, and whereas, what you can say, uh, proteolytic enzymes are in inactive form, which are activated by the uh, other enzymes. Okay, so this is exocrine function, what we are discussing right now. So amylase, they are the one which break down carbohydrates like starch, like glycogen, to glucose, maltose, and endopeptidases. They are the one which break down proteins. Trypsinogen, or when it is activated, it is trypsin form or chymotrypsin. They also break down proteins. Then there is elastases, which break down proteins. Then there is exopeptides, they digest or they break down proteins. And then there is lipases, which break down fats, okay, like triglycerides into monoglycerides. So this is how they function. So and endocrine function, we know, we, pancreas is the one which releases insulin, glucagon, and somatostatin, and then there is one thing called as pancreatic polypeptide, right? So what is the importance of this thing, guys? Simply they are endocrine function, and I think you have already covered diabetes. So of course, like in endocrinology, you know, if there is endocrine function, so you already studied that thing in endocrinology, okay? And I think you all know the function of insulin. What is the function of insulin? And what is the function of glucagon? What is the function of somatostatin? Okay, so you can see like this is one of the condition which is related to pancreas, but of course we are not going to cover that because pancreatitis is already covered. You have done in internal medicine, but pancreatitis is very important when it comes to pancreas. Pancreatitis is a very important topic, and whenever anyone suffer with pancreatitis, how we treat them, we have to give rest to the pancreas. And how we can give rest to the pancreas? Now, see, we were talking about the pancreatic enzymes or the digestive juices which pancreas produce. So if we want to give rest to pancreas, what we must do? We must let the pancreas to rest and not to produce much of the enzymes or the digestive juices. So basically what we do is like we put the patients on nothing per oral. We don't let them anything take by the mouth, okay? And even like when we start the patient on oral diet, you can say, so they are given liquids or very low fat diet or very low protein diet, okay? So and acute pancreatitis have a lot of causes, uh, like gallstones, alcohol, and drugs, and snake bite, and autoimmune causes. Like there is a lot of causes of pancreatitis. Uh, so mostly, whenever anyone have acute pancreatitis, uh, like surgical intervention is really needed, right? Uh, of course, because the pancreatitis, you know, the patient recover within 24 to 48 hours. They start improving in most of the cases. But surgical intervention is needed, for example, in case of biliary pancreatitis, to remove the obstruction, to remove the stone, okay? And mostly surgical intervention is needed in case of okay, I'm just passing this etiologies because you know we don't need it. We have done right this thing. Okay, so surgical intervention is basically needed for the complications, right? So what are the complications or what are the complications in which surgical intervention is needed? Is basically, you know, like for example, someone who have a life threatening type of pancreatitis, and what will happen that this life threatening type of pancreatitis lead to pancreatic necrosis. So maybe in that case, surgical intervention is needed, of course, to remove the necrotic part. Number one. Okay. Other than that, surgical intervention sometimes is needed, not all the time. Whenever there is some complication like pseudocyst, when the patient develops pseudocyst, so what happens? Like there is fluid collection inside their abdomen, and to remove that fluid, by the way, what they do is like they follow up or they measure the size of the pseudocyst. So again, I don't know like which book you are following, because there are different guidelines, but what I remember, under 6 centimeter, if the pseudocyst size is around 6 centimeter or less than that, there is no need of any surgical intervention. It can resolve on itself. But if the pseudocyst size is increasing, then what they do, if it is recurring again and again. Remember, pseudocyst is a complication of acute pancreatitis or pancreatitis, right? So whenever someone is having pseudocyst, surgical intervention is needed in that case when you have to make a shunt. What they do? They shunt that pancreatic fluid inside the tummy, inside the abdomen. By the way, nowadays, because nowadays this ultrasonography techniques are available everywhere. So nowadays, what they do, like they remove it by the help of aspiration. Okay, under ultrasound guidance, aspiration. So this thing is important. Okay. So now what we are going to cover is okay. Sorry, I'm passing it fast because these are all medical causes, not surgical causes. So that's why I'm passing them. Okay. Uh, Chronic pancreatitis, as we know, like when the pancreatitis is there for a chronic period, so it can lead to chronic pancreatitis. And see, uh, if you will see over here, the CT scanning, what you can see is calcifications, right? Calcified areas. So this means like this patient have chronic pancreatitis. So anyone who have chronic pancreatitis, so what they do, like of course uh, they provide them with the or they provide them, because they cannot make pancreatic juices, so they replace the enzymes. Okay, it comes in tablet forms nowadays. Pancreatic, like someone whose pancreas is not working, so of course to help digestion, they must take pancreatic enzyme, so they give it in the form of tablets. Okay, so this is what happens. So now of course, like the important thing here is to talk about what you can say pancreatic carcinoma. Okay, carcinoma of the pancreas. Like this is of course like the main surgical topic which we are going to cover. Because in surgery, of course, like one of the thing is trauma. Pancreatic trauma is also surgical thing. But as far as what you can say trauma is concerned, again spleen is more important, and again liver is more important. Uh, Even bladder is more important, I think. But like of course, like trauma can damage any structure in the abdomen, especially the deceleration injuries can damage any type of what you can say organ. But the important thing is like the carcinoma of the pancreas, and that's that like we are going to cover this carcinoma of the pancreas in this lecture. Okay, so now carcinoma of the pancreas, what is the importance of this thing of pancreatic carcinoma? Now again, like there are different what you can say statistics which are available in different books, telling you the importance of pancreatic carcinoma. Again, depending on what book you are following. For example, if you are studying Bailey's book of surgery, right? Bailey's and Love, which like most of the people they say Bailey's and Love. So if you're following that, of course, like they will give you the statistics of UK, for example. Okay, so you can see over here, like depending on what book you are studying, of course, like they are going to give you example of that country, USA, UK, Canada, or countries like this, right? So if you will see pancreatic carcinoma, see the estimated new cases among the males and among the females, and the estimated deaths because of that carcinoma, the down one. So if you will see over here, estimated new cases, see, uh, a lot of cancers, like you can see, prostate is the common one in males, and in females, the breast one is the common one, right? But if you come down, only 2 to 3% of all the cancers is pancreatic carcinomas, right? And if you see from on the female side, you are not finding any pancreas over here, right? So again, like why I'm teaching you this, telling you this thing, or why I'm stressing you this thing on this thing, because like when you were studying gynecology, breast carcinoma is very important. When you're studying like prostate carcinoma, so remember that's very important. But lung carcinoma is important, colorectal carcinoma is important. But you can say like pancreatic carcinoma, it is like 2 to 3% of the times among all the cancers. 2 to 3% of cancers are pancreatic carcinomas, right? But if you will see from that point of view, what you can found is like the people, though this carcinoma is not so common, but if you will see, you will found that the death is 6% of the deaths are due to pancreatic carcinomas, which means that it causes more deaths, right? So in USA, it is the fourth highest cause of cancer death. This is one of the things to remember. Okay, so see, like the death rate is more in pancreas, right? So anyhow, let's start further. Let's go further. So you can see like over here, most of the can are in the head of the pancreas. Okay, and these are the duct cells which have neoplastic changes most of the time, and very few time it is acinar cells carcinoma, right? And because they have, like I was telling you, that they have what you can say very extensive uh, lymphatic drainage. So you can see over here metastasis and spread are mainly from the lymphatic, okay, lymphatics. So that's how it's spread so fast. Okay, so this thing now the sign and symptoms, okay, of pancreatic carcinoma. Okay, so now we know like more are basically from the duct cells. So basically they are ductal adenocarcinomas, and very few are from acinar cells. Okay, and the most common region is, most commonly, what is the place, which place of the carcinoma, pancreas get carcinoma? It is the head. Okay, and now when we talk about what you can say about the sign and symptoms. Okay, before going sign and symptoms, I think yes, one of the thing to talk about is what are the risk factors of what you can say pancreatic carcinoma. What are the things in which, like, with which they are associated? Okay, very important thing to cover in this one. So pancreatic carcinoma, the risk factors for pancreatic carcinomas are many. And the most important non-modifiable factor in pancreatic carcinoma is basically age. Okay, it occurs in old age. So like 65 and above. It is more common in males and more common in black race. Okay, black ethnic race. It is more common. So now the environmental factors which can cause carcinoma is cigarette smoking, and then there are many other genetic factors are also there. For example, there is family history. Okay, And then there are many syndromes. For example, uh, hereditary pancreatitis, or hereditary non-polyposis colorectal carcinoma. Like these, there are different syndromes. Okay, Peutz-Jeghers syndrome and things like this. So hereditary non-polyposis colorectal carcinoma, things like this. So there are different type of what you can say syndromes or associations it is associated with. Like it is more common in such kind of people. Okay, so now uh, the thing is that the pancreatic carcinoma, which is more common in the head of the pancreas, right? Less commonly at the other places. So how it is presented? You can see over here upper abdominal pain can be there, which is deep-seated and persistent distension and discomfort. Okay, of course due to mass. Now that mass can cause obstruction of a duct, and when the obstruction of the duct is there, so what will happen? The duct is blocked, and the things will started pulling up there, and the patients will can present with obstructive jaundice, right? Okay, I will tell you. See, if there is carcinoma over here, so this carcinoma is going to block the ducts. So the the duct which is coming from the gallbladder or the cystic duct, what will happen that the bilirubin is going to blocked over there, and when the bilirubin is going to blocked over there, so what will happen that there will be direct hyperbilirubinemia. Why? Because the liver is functioning fine. The liver is doing uh, conjugation, right? And the things are spilling up in the blood, leading to hyperbilirubinemia, conjugated type. So you can say like jaundice secondary to obstruction. Okay, so that is a very very important point. Okay, so basically anyone who is presented with painless jaundice, okay, always they are old age, always think about pancreatic carcinoma. So remember, now if you know the features of post-hepatic jaundice or obstructive jaundice or direct hyperbilirubinemia, right? So what will happen? See, the bile cannot go into the duodenum, and what will happen? The patient will present with dark urine and pale stools. Okay, and now one of the things which the patient will present with is because the pancreatic juices cannot reaches the duodenum, so they cannot digest fat, especially, right? Because if the saliva also have amylase. The salivary amylase can digest carbohydrates. So simply like they cannot digest because there is no bile coming, there is no pancreatic juices. So what will happen that they cannot digest the fat, especially. So when they cannot digest the fats, what happens? Like they have a bulky stools, and basically the patients they complain like the stools are difficult to flush. Okay, so we call this condition as steatorrhea. Okay, we call this condition as steatorrhea. Steatorrhea. Okay, so this is called as steatorrhea. Oh, sorry. Okay, so this is called as steatorrhea. So bulky stools Difficult to flush. Why? Because the stool contain a lot of undigested fats. Okay. So this is how they present. And there are many other symptoms like of cancer, like poor appetite, anorexia, dyspepsia, diarrhea, or constipation, nausea and vomiting if invasion to duodenum or stomach. Okay. So now this thing, weight loss and pallor and cachexia. Okay. So all these are the features of symptoms of, you can say, what you can say, pancreatic carcinoma. So of course, like we will examine these patients, and on examination, what you will get is, I think like on examination findings, I must write over here. So on examination, what you will get in these patients is, okay, it's not like this. Like always, you will get some examination findings, but whenever we get like multiple findings, so on examination, you can say, on examination, number one, you will find that the patient is jaundice. So we can say icterus. The patient will be icteric. Okay, so we can find icterus in the patient. It's jaundice, right? And we will find that they will be having low BMI, body mass index. Okay, so or maybe like you will find a history of weight loss. Okay, sometimes you can find a palpable liver or gallbladder. Okay, so you can find these things. So now this is what you can say we can found. And other findings can be anything like, for example, you can found a palpable mass in the tummy, in the abdomen, right? Of course, like this is one of the things. So this thing you can found, okay, and sometimes you can found ascites, not always, but can be supraclavicular lymph nodes. Okay, supraclavicular lymph nodes. Remember, guys, whenever there is any carcinoma in the or malignancy in the abdomen, it can lead to the supraclavicular lymph nodes enlargement, right? So this thing can be there. Okay, so after examination, of course, what you will go for clinical findings, or you can say investigations, right? So investigations which can be done. Okay, here of course, like all the investigations are written. Like see, we can check for the pancreatic enzymes. We can do a lot of blood tests. We can do for a lot of imagings. But see, depends on how the patient presents. For example, a patient is presenting. I will give you a scenario. A patient, 65 years of age, he is a smoker, and he presented to you, for example, with weight loss, anorexia, and jaundice, right? So see, now if a patient will come to me and say, I have a weight loss, anorexia, and jaundice, so the first thing I will be inquiring is about his jaundice, right? So maybe I will start with blood CP, I will start with LFTs, okay, things like this. And when I would know that, okay, this is direct hyperbilirubinemia. So I know like what are the causes, it could be some blockage. Then I will decide some imaging. For example, I will send the patient for ultrasound, for example. I'm just telling you, like, depending on how the patient is presented, okay? So now we can do blood CB or CBC. We can do liver function test, okay? And we can do ultrasonographies, we can do CT scan, okay. So a lot of investigations can be done. We can do a lymph node biopsy, for example. If a patient will come with supraclavicular lymph node enlargement, so now it will raise in your mind the possibility of intra-abdominal malignancy. You can send the patient for what? For lymph node biopsy, for example, right? So, like depending on how the patient is presented. So you can see like here tumor markers are also written CEA, CA19-9. So all this, these are elevated in most of the patients with pancreatic cancer, also in other gastrointestinal cancers, right? So now, as you can see over here, ultrasonography, CT scan, X-ray, ERCP. So of course, ultrasound is easy to do. It is convenient. It is present everywhere. It can be done without any special preparation. Just if you have equipment, you can do ultrasonography. CT scan is, the equipment is big. There would be a proper radiologist who should make the report, see the things, right? So depending on the scenario, like we can decide. But of course, like CT scan is the preferred test. Why? Because it can give you a good picture. Okay. And on CT scan, you can see like either there is any, what is the condition of the pancreas, either what you can say, we can found any lymph nodes, we can found any metastasis, for example. Okay. So CT scan, of course, is superior. On CT scan, you would know, okay, what is the size of the tumor. Okay. So you can check the tumor size. You can check if there is any invasion. You can check the lymph nodes and all those things, of course. And also we can go for MRI. Okay. So now ERCP, I discussed a lot about this one in the previous lecture. Endoscopic retrograde cholangiopancreatography. Okay. So this one is a test. For example, by this test, what we can do, you can also pass a stent. Okay. You can also pass a stent. So this thing, you can take a sample, for example. Okay. So this one, all this tests can be done. Okay. So we can go for ultrasonography, we can go for CT scan, we can go for magnetic resonance angiography, and we can go for ERCP. Okay. So all these tests can be done. But guys, the important thing is, of course, the diagnosis. So in this case, how we would be so sure that, okay, this is pancreatic carcinoma, number one. Second thing, it is of which type. So of course we need to do a biopsy. So previously, when they don't have much, what you can say, techniques were there. So what they used to do is, they used to do something called as, sorry, this one is not this type of slide which I need. Rather, I would include a slide like this. Okay. So again, this is investigations, right? So what kind of tests they do? Like before, they used to do diagnostic laparotomy. Like they used to open the tummy and they see, like, just to take the sample, they have to do this thing. Nowadays, of course, we can go for diagnostic laparoscopy. A laparoscope can be introduced, and by the help of that, of course, like they can take a lymph nodes or any type kind of sample they can take, right? So this thing, by the way, nowadays, by the way, FNA, fine needle aspiration cytology can also be done in most of the cases. Like they can take the sample just by help of small needle. But remember, guys, I always say this thing, that whenever anyone is diagnosed with cancer, okay, Uh, then there is something which is called as diagnostic. This what we were discussing was diagnostic workup. And then comes the staging. So for staging, of course, we run different CT scans. So you can say staging workup should be done. Staging workup should be done. Okay. Of course, once the diagnosis is done, then you will do staging workup. Okay. So in staging, of course, like this, that the tumor is classified again, TNM staging. T is for tumor, N is for nodes, and M is for metastasis. So, for example, someone whose tumor is less than 2 centimeter of size, it is T1. Then when the tumor is more than 2 centimeter of size, it is T2. So when there is no nodal involvement, it is NX, and when there is no metastasis, it is N0, and when there is metastasis, it is N1. Okay. Sorry, when there is nodal involvement, it is N1, and when there is distant metastasis, it is M1. Okay. So remember, staging should be done. Okay. And TNM staging, it's not important to remember that, but it's very important to know the concept of what is basically TNM staging. Okay. What is TNM staging? You must know this thing. So anyhow, first we diagnose. Once we know it is carcinoma, we do staging workup. And then we go for treatment. Okay. Now the bad thing about this carcinoma is, as I told you in the start, that the mortality is high. Okay. So basically the bad thing about this carcinoma is what? That at the time of what you can say diagnosis, most of the patients, they already are at such a stage that the tumor is non-resectable. Okay. So more than 85% of the patients with ductal adenocarcinoma are basically having advanced disease. It is not resectable. So of course, if the tumor is resectable, you will go for resection. But if the tumor is not resectable, then of course you have to do palliative therapy. Okay. So you can see over here, pancreatic resection for pancreatic cancer is appropriate only if all gross tumor can be removed with the standard resection. For curable lesions of the head, pancreatoduodenectomy can be done, and which is called as Whipple's operation, right? I told you about Whipple's operation in the previous lecture. Like I told you, like it's better to see it online, right? Because in YouTube, nowadays there is a lot of nice animations. Like when you will see some surgery in animated form, of course you are going to remember that. Okay, actually what they are doing. Like instead of I'm trying to explain you what they are doing, right? So of course, Whipple procedure, and you can see what is Whipple procedure. It is basically pancreatoduodenectomy. Okay. So what they do, they remove the duodenum. See, it is duodenectomy. They remove the pancreas. Okay, like pancreatic head, and they remove the distal part of the bile duct. Okay. So that's the important thing. And then of course, like they anastomose all the structures back, right? So nowadays, Whipple procedure is not much used, but before, of course, like Whipple is the name of the guy who basically devised this surgery. So anyhow, that thing is done. Nowadays, this PPPD is done, okay, which is basically preserve the antrum, what you can say approach, okay. This is how they do this thing. So PPPD is basically pylorus preserving pancreatoduodenectomy. So you have to preserve the pylorus. So this is pylorus preserving pancreatoduodenectomy. Okay, in which they preserve the pylorus. Okay, so what they do, they remove the tumor. Okay, but they preserve the pylorus. So this is what is done nowadays. So one of the things which they can do is basically called as total pancreatectomy. Okay. Okay, so anyhow, these are some of the photographs, right, which are there. So all the surgeries, see how they remove the area and then they re-anastomose that. So total pancreatectomy can also be done. Okay, but of course when the tumor is either too big or at different places. Okay, and of course they remove the lymph nodes around that area. Okay, and this is what to do. And if the condition is unresectable, for example, so radiotherapy should be combined with chemotherapy, okay, for palliation. Of course, to reduce the size of that tumor. Of course, like some if someone have a unresectable tumor, or you can say it's a very advanced stage, so to remove the to deal with the symptoms, what they do, like they can do a stenting, they can give chemo radiation therapy to reduce the size of that tumor, right? So this thing can be done. So what you can say, this is how they do the procedure. Okay, and guys, this is a specialized type of surgery. Of course, cannot be done everywhere. Of course, like uh, what you can say, just good centers can do surgeries like this. So the 5-year survival rate is around 7 to 25%. Okay, so not so good, because most of the people, when they are diagnosed, the disease is already at this advanced stage. And of course, like the patients who cannot go undergo surgery, then they do like some sort of stenting, or they can put a duodenal stent. They have a lot of pain, so what they do, like they give a lot of analgesic drugs. Sometimes uh, they give a celiac plexus block to control the pain. Okay, they give them enzymes by mouth. They treat their diabetes and things like this. Okay, so we call that thing as palliation or palliative therapy. So only those things can be done for those patients. Okay, so nothing much can be done other than that. The last thing is carcinoma of the ampulla of Vater. Of course, like uh, this one is like the carcinoma of this place, right? Okay, so of course, like they will be presenting with jaundice at very early stage. Why? Because it is going to block the bile flow right from the start, and gallbladder will be enlarged, liver will be enlarged. It can get infected, so the patient can present with chills and fever, abdominal pain, and of course, like these are the constitutional symptoms of carcinoma, like weight loss, poor appetite, diarrhea, nausea, vomiting. So ERCP is best for diagnosis in this case. Okay, and of course the treatment is pancreaticoduodenectomy. So again, after that anastomosis. Okay, so this is like all about what you can say the carcinoma of the pancreas, and of course, like uh, when you will study from any surgery book, you would know that again carcinomas are like because I was talking about this one type of carcinoma, but again, like there can be a carcinoma of ampulla of Vater, there can be a carcinoma of islet cells, there can be a carcinoma of SNR cells, there is a carcinoma of ductal cells. So carcinoma can be of multiple places, but what we have to study is the most common one. Okay, so I hope you understand. Thank you so much for listening, guys. I will see you in the next lecture.